Welcome to Policy Talk. My name is Jimmy Sellers with the Partnership for Community Action, and I'm joined today with the Director of Policy from Good Business Colorado, Angelique Espinoza. Welcome, Angelique.
Thanks for having me again. It's been a pleasure to be here last time, and I'm looking forward to it again today.
Today, we're going to be talking about the Colorado option. A lot has changed since the first time we heard about it, and it's a little wonky. Where do you want to start, Angelique?
It has been crazy. There have been a lot of changes since the first time that we spoke. And I think what might be helpful is to just come back to what the main purposes of the bill were and what the side-by-side analysis is of what the changes are that have happened since then. And then maybe we'll cover what the status of the bill is now and what it still has to go through to become law.
So we're talking about the Colorado public option. What's changed since we first talked about this?
Well, the Colorado option is not actually public. It was marginally public in the first place. It was going to be run by a quasi-governmental entity. But that, in fact, is one of the big changes, the biggest change, I'd say, between when the bill was introduced and the first time it actually was up in committee. So we actually had a really exciting and interesting time following this because it was probably 3 weeks between when it was first introduced and when it finally got introduced in committee. And the reason was that the sponsors were talking with the opponents and trying to get a negotiated bill where the opponents would back off a little and give the bill more of a chance to actually get through. Sometimes this happens where you try to make all your compromises at the front end, and then you hope that you have easier sailing once you're over that big challenge. So they negotiated with the hospital association and the insurance carriers and a particular medical society that represents some doctors, but not all. And they were able to come to an agreement that talked the hospital and the insurance carriers off of the edge. But the medical society was still hunting for bear when they finally went into debate. But the big concession they made was they took out the public part. That's really what I'm getting at. And instead of having the bill be that the insurance carriers would have 2 years to meet the premium reduction cost targets, and after that, if they couldn't do it, then the state of Colorado would create this quasi-governmental entity to offer the plans. They scrapped the quasi-governmental entity and said, if you can't get to the place where the targets are in 3 years, then you will need to go into public hearings to justify why you couldn't meet the plan. So that's it. They've changed the size and shape of the stick in this case.
Can you share with us what the other changes have been since the bill was introduced?
All right, so here is the side by side of those other pieces that are different. So if you recall, when they first introduced the bill, they were looking at hitting premium reductions of 20% over 2 years. Now they're looking at 18% over 3 years. Originally, it was going to be a two-phased approach, which we just talked about. The second phase would be that the quasi-governmental entity would offer the plan. And now there's only one phase, spread over 3 years. The state will define the plan, and the private insurance carriers will be required to offer them. It still makes insurance coverage cheaper and more accessible. It has lower out-of-pocket costs for people and small businesses. And one of the really cool things about it is that it prioritizes health equity. In the original one, in the original version, the standardized plan had to be designed to improve racial equality, racial health equity, sorry, and decrease racial health disparities. And that's stayed in the bill as it's gotten changed. And additionally, that piece has actually been strengthened in the new version. So one of the things that people run into, especially in rural areas, but in places where a lot of folks are needing to get specialty care, is that they might find that they have to travel in order to, or go out of network in order to get specialty care because the coverage isn't good enough. That means that they don't have an adequate network, their plan. So this requires that the insurance carriers have to create networks that are more diverse and equitable. So they're going to have to try and diversify their pool of providers. And then they're also supposed to provide descriptions of how they're going to do that in their network access plans. Then we're still going to have coverage for everyone. So this will be also available to immigrant families, regardless of their documentation status. Yeah.
That's amazing. That's amazing.
Because, you know, whether you have papers or not, you still get sick.
Yeah.
And we're all, you know, we're all impacted by each other's health. So it just doesn't make sense to leave that piece out.
Absolutely.
There's still a standardized plan. And that's actually going to be developed in partnership with diverse stakeholders. So it won't just be some government bureaucrat saying, here's what the plan should be. They're actually going to have a table of stakeholders that includes a doctor and people from diverse communities and people with knowledge about how insurance plans work. And there's just a whole huge definition of who needs to be at the table in order to make a plan that makes sense. Here's a big part for us. It still has relief for small businesses, including the small group market. This was a tough one. The insurance carriers did not want to include small groups in the plan. And we are really grateful to our sponsors for drawing a line in the sand on that one and making sure that small groups stayed in the bill. Yeah, exactly. Another piece that's really important is that rural hospitals and critical access hospitals who serve sensitive populations, people who are on Medicare, Medicaid, or uninsured, those hospitals will have some protections in the bill. So they won't, they will have some ability, some flexibility around the requirements to make sure that they're not negatively impacted. And that was part of the introduced bill, but in the compromise bill, again, it's strengthened. So what they've done is they have created a reimbursement rates for hospitals. And those reimbursement rates will have floors. So it can't go below a certain amount. And if you are a hospital that serves a large proportion of the uninsured or Medicare, Medicaid patients, your floor is going to be higher. So you will get a bigger reimbursement rate. And then if you're a critical access hospital, then there's kind of an additional percentage point. So you kind of get points for kind of different areas that you might serve, independent hospitals as well. And this really makes it work for everyone. I know that earlier the industry was really trying to fluff up the opposition with the idea that somehow this was going to disadvantage communities of color, communities of poverty, because those hospitals would be negatively impacted. But not only was that already handled in the original bill, but it's even more so in the compromise bill. So we feel really good about the ability of our hospitals across the state to serve their patients and to stay open. There's a real interesting financial piece of this. I don't know if you recall, but we talked about this thing that's called a federal 1332 waiver. And it is federal money, basically, that comes to the state if the state is able to reduce their healthcare premiums such that the federal government then doesn't have to give as many tax credits for people who are paying higher rates for healthcare. So the federal government saves some money because of what the state is doing, and then the federal government returns that money to the state, and the state can use it to help with what they're doing in healthcare. So originally that money was going to go to stand up the quasi-governmental entity. Since that's not happening anymore, it's now going to be used to assist Coloradans in paying for their health insurance. Both the original and the new improved version work within the existing model, work within the existing market, meaning it's not like a public one-payer plan. And as I said, this one is going to be offered through the private carriers, and they will all be required to offer the standardized plans. If they don't do that, or they're unable to meet the network adequacy requirements, then they're going to go through a new public hearing process to address any issues that there are with them being able to hit those targets and provide network adequacy. And there also is going to be a first ever health insurance consumer ombudsperson, which I think is going to be really helpful for people in navigating this. And then the last pieces are, in the original bill, providers were going to be, it was going to be mandatory that providers would participate. And if they didn't, they would actually have potentially their licenses revoked. And this was a tough one. And fortunately, it has been changed. So it's no longer mandatory or tied to licensure. Providers can only be required to participate if the network adequacy isn't met. So if there's a provider that really has to be in a network in order for them to have network adequacy, then they can be compelled through the use of a fine. So it still doesn't impact licensure. And a recent amendment that was made on the floor during the 9-hour debate was that those fines could only be levied once per year. So it provides a lot more flexibility for providers, but still a very strong encouragement to participate. And then the rate floors. So the previous version didn't have any reimbursement floor in the rates. And this one, they won't set the rates unless the reimbursement rates, unless the carriers can't meet the targets. If they don't meet the targets, then the state can set reimbursement rates both for hospitals and for providers. For hospitals, it can't be lower than 165% of Medicare. And for providers, it cannot be lower than 135% of Medicare for any specific provider. And then this is the part where, as I mentioned, they have a reimbursement formula that gives a little extra percentage points to rural hospitals, critical access hospitals, independent hospitals, ones with a higher mix of patients who are low income, don't have insurance, or on those lower reimbursement plans.
Angelique, you brought up earlier that they were debating on the floor for 9 hours. Where are we now with this bill?
So after the 9 hours of debate at around 2 in the morning, the bill passed on the floor on the second reading. It still has to go through a third reading, which we hope will be uneventful and will probably be scheduled for Monday, which I guess is the 10th. And then once it passes off the floor of the House, it goes to the Senate. And then the Senate introduces it and assigns it to a committee. And it goes through the Senate process. And then if the Senate makes any amendments, any additional amendments, it will have to go to conference. And the two representatives from the two chambers will have to work out which version or which combination of versions they're going to go with. So it does still have, it's halfway there, if you will, or it will be pretty much once it passes third reading. It could still face some challenges in the Senate, particularly with the Colorado Medical Association or Society, I forgot which. They really activated a lot of doctors, particularly specialists, who were, who they kind of gave their message to, and they felt like that was going to move legislators to hear from doctors. Now, fortunately, the proponents were also able to bring doctors to the table, a lot of primary care doctors, to say, hey, I see patients all the time that are not getting the care that they need, and it's just we can't keep doing this. And so I think that's been a successful way to begin to address that message. But I wouldn't be surprised to see the Colorado Medical Association continue to press for amendments when it goes to the Senate. I don't think it's going to be super effective, again, because there's already a compromise bill on the table, but we'll see. It's been a heck of a road so far. So it'll be really important for us to keep advocating and keep letting our senators know how important this is, particularly if you have friends who are doctors. I have a friend actually who's a primary care doctor, and I told her about this, and she said, oh, absolutely, let me know when I can testify, and I'd be glad to. So it's going to be important to keep up the fight.
Angelique, can you share with people how they might contribute to the conversation around this bill in the House and the Senate by sharing their stories or testifying? What is it that they can do?
Oh, yes. Yeah, folks haven't already submitted their stories or let us know, what their challenges have been and how important this could be to really make their lives better. That would be a great thing to contact us with. We will continue to collect those stories. And when the time comes that it actually is scheduled for a Senate committee meeting, we can reach back out and ask if we can submit it as a written testimony, or if you're interested in testifying remotely, we can help and support you through that process as well. And it's so much easier to do it this year because you don't have to go to the Capitol. So it's a great time to testify because it's a lot easier than it was before.
Angelique, is there anything that you would like to add before we close today?
I just have been really impressed with the sponsors of the bill, Representative Dillon and Representative Iman. Senator Donovan is going to carry it in the Senate, but working with the sponsors and working with the coalition with Healthier Colorado and the Colorado Consumer Health Initiative and groups that serve communities of color, Color, and just great people, such amazing people have been working together on this bill that I think is really going to change people's lives for the better, and going to feel great once this gets to the governor's desk and gets signed.
Well, thank you, Angelique. We're looking forward to hearing how this all plays out over the next few weeks as it goes into the Senate. And hopefully we'll have a couple of more conversations before the final bill. Thanks so much for joining us.
Thank you so much for having me. It's always a pleasure talking with you.